populations in the US. Then we're going to dive into the case study of Puerto Rico, and then we'll move to the case study of Delaware. And hopefully at the end, we'll have recommendations and an exchange with all of you. So welcome to this workshop. We're really excited to have you join us. So let's go to the next slide. My colleague. Yes, so my colleague Alicia is going to take it from here. Alicia.
Thank you. Good morning, everybody, or good afternoon, depending on where you are. Currently sitting in California, so it's still morning. We're going to be using different terms. Predominantly, we're going to be using the term Latinx, but certainly there's a lot of different terminologies. So Latinx, Hispanic, we might be interchanging them. So this refers to any person of Cuban, Mexican, Puerto Rican, South or Central American or other Spanish culture or origin, regardless of race. So ethnicity, not race. Currently in the United States, we have 60.5 million Hispanics, Latinx folks, and that is about 18% of the total population. About 61% are Mexican, Mexican-American, 10% Puerto Rican, 10% Central American, 6% South American, 4% Cuban. It's a very young population. 31% of Hispanics are under 18 years old versus 90% of non-Hispanics. So like all populations, Latinx health and health disparities are shaped by lots of different factors. Social determinants of health, language, and cultural barriers are a significant factor. 71% of Latinx folks in the United States speak a language other than English at home. For most of those folks, it's Spanish, but certainly there are other indigenous languages. And 28% say that they're not fluent in English. Lack of health insurance and healthcare access is a major force that shapes health and health disparities for Latinx families. Hispanics and Latinos have the highest uninsurance rate of any racial or ethnic group within the United States. And this is 19% of Latinx folks are uninsured versus 6% of non-Hispanic whites. Only about 50% of Hispanics versus 3/4 of non-Hispanic whites have private insurance, and certainly not having insurance, as we know, in the United States where healthcare is so expensive, leads to lower utilization of preventive care, cancer screening, prenatal care, all that sort of stuff, regardless of programs that are designed to help support lower income folks. There's also lower rates of education and higher levels of poverty within this population. So 71% versus 93% of non-Hispanic whites had a high school diploma or higher. And among full-time year-round workers in 2019, the average Hispanic Latino median household income was about $56,000, while this was around $72,000 for non-Hispanic white households. And then 17% of Hispanics versus 9% of non-Hispanics whites were living at the poverty level. While this doesn't apply to everyone or even the majority of folks, immigration and health policies really do shape health for this population. So there are immigration laws and policies that explicitly provide or restrict access to health services. The Personal Responsibility and Work Opportunity Act of 1996 is one example of that has reduced access to health care, SNAP or food stamps, housing subsidies, disability benefits, and has created a lot of fear in the community. There's also public charge rules that have been on the books that really result in fear and parents in particular making decisions to not enroll children into programs that can support their health because their fear that would negatively impact future applications for citizenship. Really, there's a lot of fear of agencies sharing information with other immigration agencies. And this fear is actually, it is a prevalent widely among folks, regardless of immigration status. And then things like 287G, where our ICE has contracts with police officers, allowing them to detain, has really increased the fear in the community. But we do have some policies that are health supporting, like DACA, which have led to improved social determinants of health. Studies have shown that this leads to improved educational attainment, economic stability, healthcare access, all good things. There are a lot of disparities. I'm just going to give a couple high levels. Leading causes of illness and death among Latinx populations are heart disease, cancer, unintentional injuries, stroke and diabetes, and some other health conditions and risk factors that significantly impact this population are asthma, chronic obstructive pulmonary disease, HIV/AIDS, obesity, suicide, and liver disease. And certainly we see in the population-wide that Hispanics have higher rates of obesity than non-Hispanic whites. And both men and women have chronic liver disease that's about 2 times that of non-Hispanic whites. Latinos are 2 times more likely to visit the emergency department for asthma than non-Hispanic whites, and Hispanic and Latino children are 40% more likely to die from asthma than non-Hispanic white children. And one really important distinction to make here is that while we're grouping everyone in a pot called Hispanic or Latino, there are very different rates of disease and health among the different populations, the different ethnic groups. So, for example, although rates of lower birth weight infants is lower for the total Hispanic Latino population compared to non-Hispanic whites, Puerto Ricans have a low birth rate that is almost twice that of non-Hispanic whites. So different disparities. Also, not to pick on Puerto Ricans, of course, but there's disproportionate rates of asthma, HIV/AIDS, and infant mortality among this population as well. And Puerto Ricans also have a lot of disparities with regard to asthma. They have twice the asthma rates of other Hispanics, and Puerto Rican children are 3 times as likely to have asthma than non-Hispanic whites. And Mexican Americans suffer disproportionately from diabetes. And just a few quick stats before I turn it back over. In 2018, Hispanic Latinos were 1.3 times more likely than non-Hispanic whites to die from diabetes, and adults were 70% more likely than non-Hispanic white adults to be diagnosed by diabetes by a physician. And then 2017, Hispanics were twice as likely to be hospitalized for treatment of end-stage renal disease related to diabetes as compared to non-Hispanic whites. There are a lot of other disparities, but just a high level. So moving on, I'd like to invite the Puerto Rican colleagues to take it away.
Yes. So as you can see, Latinos are a very diverse group of people with language being one thing in common, but we come from extensive geographic areas. In this case, we are coming from an island in the Caribbean, Puerto Rico, who became part of the United States in 1898 after the Hispanic American War. And so Puerto Rico, Guam, the Philippines were passed from the Spanish Empire to the United States. And Puerto Ricans have been citizens since 1917. So taking all of that into account, we're the most populous territory of the US from the territorial jurisdictions. And what we're gonna present you, it's about Puerto Ricans who live in the island. And I wanted to make that clarification because we're a very diverse group of people. There's as many of us in the island as there are in the mainland. And there are some commonalities and some differences. This is part of our team. We're part of a collaboration between 3 universities, highly feminine group of people. Next slide. And then we are in partnership with the Instituto Tercera Misión from Albizu University. Kayla and Jan are here. They're our partners in the whole process that we're gonna show you of our community consultations. Let's go to next slide. So the goals of the Alliance are to integrate, to close the gap, and to address health conditions, and basically work towards bringing scientific innovation into service for community. That's the reason we exist. Let's go to the next one. And our community core really tries to catalyze community academic partnerships, and it has done a great job in our previous iteration. We've been together for about 11 years. And so we have established under Edna's leadership this beautiful community academic partnerships. Today, we're not going to talk about that, but I wanted to recognize that work. And through this work, we want to identify key health conditions needing attention. So in order to do that, let's go to the next one. You know, one of the things we took into account in order to contribute to science, it's the context in which we exist. And the Alliance exists in the context of Puerto Ricans in the island. And so our work really comes from a multidimensional lens that takes into account how we're defined in many different ways through intersectionality of different identities, also taking into account historical trauma and scientific equity. This has been poignant as recently as 2 weeks ago when the Supreme Court of the United States ratified that Puerto Ricans in the islands are going to continue to be excluded of social aid funding. So the issue of access for us living under a colonial situation in our relationship with the United States really impacts the way health conditions happen in Puerto Rico. Let's go to the next one. So intersectionality, this lens talks about how we have many identities, you know, gender, social class, colonial status, all of those things. Let's go to the next one. Historical trauma talks about how groups of people like us who have been under political conditions that are difficult for so many years, that impacts health outcomes in people. Let's go to the next one. And it is passed from generation through generation. So that's important to take into account when thinking of working in health issues. Can we go to the next one? Thank you. So, you know, that goes from taking into account invisibility issues to, you know, what's the recovery capacity of communities and really talking about it openly. Let's go to the next one. And finally, you know, we aspire as social scientists in our team to really work for scientific equity. Our goal with the Alliance is to really bring forth this issue so that we can really help change the topography of health conditions for Puerto Ricans in the island. Let's go to the next one, or for anybody who lives in the island, because we have a lot of immigrant populations. So how we have gone about doing this is establishing a health council that is comprised of community members, having listening sessions all over Puerto Rico, and really working with our leadership to hone down of what the community is telling us are their needs. Let's go to the next one. So in order to do all of this, we went about doing, we talked to our community council and they really told us, based on the data and epidemiology, what's happening in the island, these were the hit parade, the 7 highest areas that we should focus on. So we constructed all of our community forums around these topics. Let's go to the next one. Originally, the pandemic helped us because it freed us from our original design of geographic participation, and really through the digital platforms, we got rid of that nuance. Anybody could participate. Initially, we proposed to have 120 some participants. This afforded us the opportunity to have 200 and some participants. And let's go to the next slide, Alicia, please. And we had more reach than we had designed originally prior to COVID. So we were able, Puerto Rico is an archipelago, and we are organized by municipalities, equivalent to counties in your world. So we were able to have participation for 51 out of the 78 municipalities. And obviously the face of the participation reflects our demographics, mostly female. And there were people, let's go to the next slide, both from the community as well as people who serve the community or legislate for the community, the whole rainbow of people. This is the structure that we had for our meetings. Let's go to the next one. So we set up this innovative structure where we gave a little bit of the state of the situation of each of those 7 issues. And then we moved to talk about the antidote as seen by the community, asking them questions. And then we had a session where they spoke about what would be accountability for them, what they needed the Alliance to address on those 7 main issues in order for community outcomes to improve. So that was the structure of each session. Let's go to the next one. And I'm gonna ask Edna to take it from here. We did 8 forums in 1 year. Go ahead, Edna.
Oh, yes. Thank you. This is more or less like the promotion that we use for every call. We try to use a very vivid pictures to call the community to join us, as well as to talk to our community partners to make sure that whoever had something to say was there. The next one, please. So at the end, we had this 8 community forums. We had to do a second round of the people with disabilities to have one related to autism. So we did these communities forums, and one of the challenges was, combining and restructuring and somehow synthesizing all the information that was gathered to this massive needs assessment. So we call on our partners, on our community. It's okay, Alicia, you can have the next one. So this is like a summary of the 30 important issues that each community forum identify. The mission was to have at least 3 priorities that the community thought it was important with the research to, make sure we take priority in researches and health issues. And then we asked all our community partners, including the Hispanic Alliance leaders and our community advisory board, to make sure that we fine-tune those priorities. So we did this exercise of asking, what are the priorities? Where is some political willingness to do this work, and where do we have resources, to make sure that we address them? So making it more accountable for us to make sure that we can make an effort to move the agenda toward the health equity.
So the community identified 30 some, if you count the squares, needs. And then the alliance leaders prioritize what you see in yellow as the ones where the alliance has the resources, the political will, and the know-how to partner with community members to work on them. COVID, as you can see in the bottom, was across all of the forums. It came out. And the topics are, there's a lot of access things, a lot of mental health issues. And we're going to walk you through now a little bit more detail of the top priorities. Alicia, we can go to the next one. Next one.
You could double click again, just to make sure we have the other box. There you go. So we did this exercise to try to come up to a multi-level interventions that we will be able to attend all these issues. So we asked our partners to make sure to identify practices, policies, and programs that we can structure to prioritize all these priorities, the aspects for the health.
Let me add something there. For us, conceptually, it's really important. We are firm believers, and our bias is that we're community psychologists, so I should say that, but our belief is that if you want to change the topography of community, you must do multi-level interventions whenever possible. So we really push our partners to think in a multi-level way. Not all the time with all the issues is possible, but we ask them to produce as many changes in policies, practices, and programs that they could think of to address these issues that the community is telling us they need assistance with. And what came out of that, it's 47 strategies. They did a really good job. We pushed them hard. Let's go to the next one. And it's going to tell you a little bit about the top ones.
Yeah.
These are just examples, so you can, there we go.
So we had 2 rounds of priorities. The first one is this one. It was organized through people that are living homelessness, people that have been experiencing trauma, and people that have been kept in distance and invisibility due to the disasters and emergency we have been around. So COVID is one of the main focus, like Marisaida said, and then people want us to organize the access to services based on mental health and trauma aspects. And then we had a second round because it was too much information to handle in just one round. And in the second round, we have a set of priorities that we were able to organize in the next one. And those would be access to health services, integral services, education, training, and capacity building, mostly to health providers in order to, make sure that all those services are being taken care of. Awareness and accessibility. One of the main issues we explore is the need to have a new generation of professionals that are more sensible to diversity within our community as well. Data harmonization to make sure that at the governmental level, the academic level, and the community level, data is shared so we can make better use of the information that we have currently to make better decisions. Something else you want to add, Mari?
Unique to our colonial status is that some people call it paper genocide academically, but that we're invisible in many of the national surveys that other jurisdictions might have available in the United States. Either we're not included by design or we're included intermittently, which puts further burden in our jurisdiction to produce its own data to make data-driven decision-making. And it's a cycle because it's very expensive to keep it up. And so that's one of the issues, access to reliable data to make data-driven decision-making, and an absence or invisibility in national surveys that are subsidized by the federal government has become quite an issue for us historically. So it makes our work interesting. Let's go to the next slide. Yeah, so back to you, Edna.
It's okay. Now, with all that information and the priorities we have been able to identify with the programming and the politics and the practices that have been developed, our next challenge is how to make sure we disseminate this strategy to all the sphere, not only at the academic level, but also at the governmental, the community, and all the sectors that were involved in these community forums. So we have identified non-traditional ways to make sure that the voices stay out there, that our researchers have this information at hand to make decisions on the community engaged research or any other research in the spectrum of the translational research efforts. Of course, the typical products are writing and public make sure that we publication, how you say?
Peer-reviewed articles.
Thank you. So we are making sure that you and other colleagues know about these efforts. And we also have some stories to tell about how we are able to make changes at the policy level. So we will be doing some video captures, kind of interview, TV shows, series to tell the experiences of our researchers to making changes at the policy level with the data they have been collecting so far.
Hopefully we'll come back to visit you next year and show us. We have put a lot of effort into this non-traditional dissemination. Today, we're not talking about it. We're in the process of developing them, but I think next year we'll be able to share how it went. And our idea is to keep the community forums open throughout the year so that people can go through social media and continue to give feedback live. So we have never done that before. It's going to be interesting how it turns out. So we'll keep you posted. So let's go to the next slide. So I think this is the end of us showing you a little bit of what's going on in Puerto Rico. We have a very extensive partnership within and outside of the island with colleagues, and we appreciate the interest and the opportunity to show you what's going on with Puerto Rican communities in Puerto Rico. So now Alicia is going to talk a little bit about what's going on with Latinx communities in Delaware.
Thank you. That was wonderful. I'm wondering if we just want to take one or two questions for you all before we go to Delaware.
Yes, if time permits, questions or comments, we'll be happy. Keishla has been monitoring this chat as well. So
I was going to ask, this is Levada White. I was going to ask, with the 78 municipalities that you did your study in, who were the participants? Were they the homeless and underserved themselves, or did you reach out to other
We had members of the target community themselves, as well as service providers. We had, people who work in nonprofit organizations, people who work in the universities, people who work for the state, policymakers.
We had some community leaders that are themselves users of the services as well.
That's what I wanted to know. What was the ratio of the target population rather than the providers?
We could not set it up to have a high participation of people who are homeless, although we had participation of community-based organizations who are very prominent here and provide services for that community. On the flip side, with the immigrant one, we partner with the Dominican Women's Center. So we have a high participation. And with the disabilities, we had to create an additional forum because we had a lot of parents or caretakers of people with disabilities. So we ended up doing a forum about adults and then a forum just for parents of children with disabilities.
Yeah. I don't have the rate number right here, and I don't know it by memory, but I can assure it was very well balanced when we saw those numbers at the end. Our only main concern was on the youth side. We didn't have too many voices of our youth and kids. So that's one of our to-do list in the agenda, to provoke another movement where we can have the voices of the youth members and the kids to talk about.
Yeah, and that requires a different kind of setup, which we do have in other projects, but within the Alliance, we didn't have this setup to do the forums in a way that was conducive for the participation of children and youth.
Thank you.
You're very welcome. Thank you for your question, Ms. White.
We have a couple of questions in the chat. It says, could you address challenges in community engagement during COVID in Puerto Rico? And we have a second question. Puerto Rico had the highest COVID vaccination rates in the US. Can you comment on the role of community engagement in this huge achievement?
Alicia, do you want us to parking lot those for the end, or do you want us to answer them now?
No, go ahead and answer them. I think we'll be okay.
I'll defer to Edna to start. Edna.
Well, in terms of the success of the achievement for the vaccination, it took the whole village, all the partners from the community, the leaders, the community organization mostly. And for, once in a lifetime, the government was aligned with those agendas and we make it work. There was a lot of funding opportunities to make this work. And we were focusing on making sure, because, in an island, you don't have many places to go. So the need to be organized was, what high.
But there's also a factor, which to me is fascinating, that you all are dealing with in the mainland that we're not, and it's the politicization of this health issue. We don't have that problem that you all have over here. Because I'm sticking to this topic, to the topic at hand, which is COVID vaccination. It hasn't been politicized the way it has been politicized in the mainland of the United States, affording us the opportunity to maintain the issue a health issue. It is a problem, and Dr. Khan has been here a lot. So you can tell who is a local and who isn't by our use of masks, right? So tourists, because they come from the mainland with that other issue, might not use the mask, but the locals, I think people are pretty disciplined in terms of understanding that this is a health issue, not a political issue, and that has protected us a lot.
Yep. Yep. And one of the challenges we expressed, we had experience and we are still experiencing is access to digital platform through the whole island. There's some pockets that still don't have access to internet. And even though the government, the educational department of education, and some organizations have been working to providing services and laptops and Wi-Fi, there's still a lot of work to do.
And not to be confused, and I'll shut up after that, Alicia, I promise, not to be confused with intersectionality. There are pockets of people in this island who are elderly, who are physically isolated. Although it's a very small place, there are some municipalities where you can be traveling for an hour, very remote. who are homeless, who are LGBTQ. So those intersections of older people who have those conditions of living are not vaccinated. And we're doing a rapid response grant just to address that. So in the surface, it looks like we're very well behaved and vaccinated, but there are pockets of people who need our help. And that's why those lenses of intersectionality are so important, because otherwise one good intentions are not enough. I'm going to shut up.
You say the road to hell is paved with good intentions. So
that's correct.
Kind of brutal. Awesome. Well, thank you guys for the questions, and thanks to my colleagues from Puerto Rico. That was super interesting. And although our contexts are pretty different, we have a lot of common challenges. So let me reshare. Okay. See. Okay, so moving to Delaware. So just a few quick stats. I'm not going to go through all of these in detail, but it estimated a little over 10% of Delaware residents self-identify as Hispanic or Latino. These are largely Mexican-American ethnicities, Puerto Rican, Central American, South American. And I just want to draw your attention to, in the rightmost table, while the vast majority of this population, 67% are employed, we see that the federal poverty levels among this population, over half, 55%, are living within 200% of poverty. And then you see that we have at least 23% of the population in 2019 who are uninsured. And almost half are foreign-born, and 72% of folks in Delaware who self-identify as Latinx or Hispanic indicate that their preferred language is Spanish. The health disparities that I talked about nationally also unfortunately play out in the context of Delaware. But here you can see here in the yellow line how this is the percentage of US adults that indicate that they're in high health status by race, ethnicity. And you can just see the trend of Hispanics basically being at the bottom continues in Delaware. So lots of work to do. We have low availability of Latinx and Spanish-speaking providers, and certainly in some areas of Delaware, we have a lot of folks working in dirty jobs, things like poultry, which we saw, really those conditions exacerbated the pandemic and its impacts on many of these folks. And, diabetes is among one of many challenges that we experience with our Hispanic Latino populations. We had an 86% increase in diabetes between 2011 and 2013, and that continues to increase. So the first, I'm just going to talk about a few different studies. The first is a study at Christiana Care. We do social needs screening, social determinants of health screening. We have 11-item screening tool that measures 10 social needs, and we are administering that. We're growing this system-wide, but these were data that were collected among about 1,500 patients in different high-need programs, obstetric triage, complex care community, which is mostly our at-risk ACO patients, older demographics, and then Healthy Latinx Families program, which is a promotora program out of our cancer center, and also we have a promotora in the Latin American Community Center in Wilmington. So I just want to show you here in yellow the population of the Healthy Latinx Families program, unsurprisingly, is largely Hispanic Latino folks, and the vast majority prefer Spanish, very low levels of Medicaid insurance coverage, and lower levels than the other patient populations in terms of access or having a primary care provider. The types of social needs reported, I have these in order. So looking at the Healthy Latinx Family Program, so within the context of care, and much of these data were collected prior to the pandemic, We saw that 57% of folks in this program were food insecure or experiencing food insecurity. 55% said they lacked healthcare access due to costs. We see over half having screening for high health literacy needs, similarly financial insecurity, and also significantly higher rates of housing quality issues like mold or water being shut off or other things. And then certainly rates of homelessness and housing insecurity were pervasive, about 10%, utility needs, interpersonal safety needs, urgent needs. And while some of these needs are similar to the majority English-speaking patient populations, you can see that overwhelmingly there are much higher rates of need. And this extends to the number of social needs as well. So you can see at the top in blue is 0. So we had 94% of the patients in our Healthy Latinx Families program having one or more social needs. And this is in comparison to, less than 50% of the obstetric triage patients and about 70% of complex care community patients. 48% of our Healthy Latinx Families patients had 4 or more needs versus 11% of the obstetric triage and 23% of the complex care community. And again, these other obstetric triage and the complex care community are also vulnerable patient populations, which just demonstrates how high a need. So I'm going to talk also briefly, keeping with the same theme of social determinants of health, about an ACCEL CTR funded program. It was jointly funded by Christiana and ACCEL, which was a community-based survey of COVID related worries, social needs, testing lots of stuff. It was a partnership between the Office of Health Equity at Christiana Care and our Healthy Latinx Families program. And we were collaborating with the Latin American Community Center and also Holy Angels Catholic Church. We wanted to understand the social and health impacts of COVID among our predominantly Spanish-speaking community in Newcastle County, which is Delaware's northernmost county and most populated. All of this work was done in November 2020 to December 2020, and it was interviewer administered in Spanish with incentives, IRB, et cetera. The folks in this 114 adults participated. They were relatively young, around 31 years, majority female. And about half were employed and a quarter worked in an essential service, and over a third had no health insurance. So you can see here, we asked about social needs before the pandemic and since the pandemic. And I think the results are really striking. So while we see disparate rates of social needs prior to the pandemic in pretty much every, versus the non-Hispanic white population of Delaware in pretty much every one of these. But we see really enormous jumps in social needs. For example, folks were already, 39% were experiencing food insecurity before the pandemic, which is, compared to roughly probably 10% of the general population. And then that jumped to almost 3/4 of participants since the pandemic. You can see the trend similarly for financial insecurity, homelessness and housing insecurity, unmet childcare needs, transportation needs, utility needs, and interpersonal safety concerns were really striking. And 92% said that their job had been impacted by the pandemic, with 32% being laid off, fired, not paid, or having their work hours decrease. And we asked folks to share with us how difficult it would be for them to meet ends meet. And you can see that 78% said that it would be very or somewhat difficult. So really, really, really high levels of social determinants of health needs and difficulty financially. I'm not going to go into all of these, but we asked people to share stories about how they were being impacted by COVID, how they were coping, and also ideas about things that needed to happen to help remedy their situations. Lots of financial impacts, difficulty with rent, food. And I'm just going to read one of these that I think, since I'm really kind of focused on food in this issue of food insecurity, one striking quote one of our participants shared was, "I lost my job I keep looking for work, but I cannot find it. I am receiving unemployment, but it's barely $63 a week. And I have 2 young children. Sometimes they open the refrigerator and it's empty. Their classes are all now at home and I don't have enough money to feed them well. So there's lots of similar stories that were shared by our participants. And as you can imagine, health and well-being was really being adversely impacted. 31% of participants rated their health as fair or poor. 38% screened positive for general anxiety disorder, high rates of depression, isolation, and many folks, over a third, said they never or rarely had someone to help them, like taking them to the doctors or buying groceries or making meals. And many people, only about a third, felt like they could look to their neighbors to help them. And again, also 20% said that they had been denied services or got more service for doctor, nurse, healthcare office, or clinic because of their skin color, language, or accent, or because of county origin or culture. And certainly these experiences combined with other barriers to really decrease the people's ability to access services they need. So I'm just very going to quickly just give a high level kind of intro to one of the programs that we're doing at Christiana Care, and it's a partnership with a community-based organization called Lutheran Community Services. This is the Delaware Food Pharmacy. It's a comprehensive intervention that involves 6 months of medically tailored groceries. This is for patients with uncontrolled diabetes, hypertension, and heart failure. It's open to all patients, including our Spanish-speaking patients. There's dietary counseling and education from community health workers and registered dietitians. There's psychosocial support provided by our behavioral health consultants. And our community health workers also do a lot of work in terms of screening for social determinants of health and making referrals. And some of our patients, like the first thing that our community health workers do with them in the program is help them to find stable housing so that they can participate. Certainly they need quality health care. We're using research, so we're using the DASH eating plan and really a food is medicine approach for this work. And this is just some of the material. So you can see from the photos here, the food that we're providing is not typical food assistance food. It's high quality food that all of us would want to eat in our houses. We provide a culinary kit of materials. They get we do dietary assessments and they get ongoing education, and also kind of ideas of an assessment of where they are at different stages in the program. And to the rightmost, these are our choice menus. So patients get to decide what food they want every week. And again, the food is not just for the patients, but for their whole family. We're currently doing some formative research with patients in our Latinx community, employees who are also much of the time our patients. We've been doing qualitative key informant interviews, and we've spoken so far with about 40 caregivers and patients. These were largely Mexican American, Puerto Rican, some other groups, and we've been asking them to describe to us what factors they feel shape health. And many of the things that have already come out in my colleagues' earlier presentation and really deal with language barriers, financial constraints, including things like transportation, and really acknowledge kind of the cultural traditions around food, and really a strong need to build trust, because people have a lot of fear and also have had adverse experience of discrimination with our system or with other systems. We are talking about food a lot, talking about different adaptations to the choice menu, and also asking people about other adaptations needed to make a version of this program that's culturally sensitive and will be offered out of our primary care practice that Christiana has acquired over the last year, that is with about 3,000 Spanish-speaking patients. We have a lot of other interventions. I'm not going into those, but I echo the sentiments of my colleagues that multi-level interventions are really where we need to go. And in the next phase of our community outreach and engagement for ACCEL, we are really focused on growing our outreach, our partnerships, and our intervention work and research with Latinx communities. So before we move into recommendations, are there any questions or comments?
Well, I was wondering how available these flyers that you have in Spanish are going to be available. Are they available yet?
The flyer?
Yeah, the ones that has like the information about the pharmacy, nutrition stuff.
The DASH eating plan. Yeah,
Yep.
yeah. No, we haven't. We're in the process of translating a lot of things, including recipes. So our, and again, we're going to have a different name. We're not going to be calling it Delaware Food Pharmacy. We're going to work with everybody to create something that's not just a translation, but is a, obviously appropriate. So this will be launched in the fall or the winter. I mean, we have our current food pharmacy and we have some Spanish-speaking patients, but our culturally adapted program is going to be launched in the fall and winter. So I'd love to chat with you guys about that because I'm sure you have a lot of good insights and experiences that can help us.
Likewise, I think, seeing all of the work you all have done around nutrition, we know in our communities, especially with the elderly, I'm looking forward to working more with you and talking about that, because that's certainly, food security is certainly an issue that it's important for us as well.
Wonderful. So I know that we only have a few more minutes, so I'm wondering if we want to move on to our recommendations, and then we can take any additional comments or questions at the end. I'll turn it over to you guys, Puerto Rica.
So for us, our reflection of recommendations have to do that. We've always believed in transdisciplinary environments, but I think doing these forums really heightened for us the need of that transdisciplinarity to address such complex social issues. So that is something that we're going to be working on very hard. Also, the good side of being virtual really liberated us from geographic boundaries. And I have to admit, if it wasn't for COVID, we wouldn't have moved to be more open to work digitally than we did before. And then working intentionally in multi-level strategies. Our team, we've worked from a collective impact perspective for many, many years. But we're the social scientist side of the Alliance. So it will be very interesting how we join forces now with our basic and clinical partners in the Alliance to really move towards that, and with our community partners. And certainly many of our professions in the Alliance, we're not trained to do policy level changes. So that's a new area of work for Alliance members. Because many of the focus on translational research, like I said, historically has been in basic science and clinical science, not in this kind of things that change structures. So we'll see how it goes. That's our reflection as a group. That's it for us, Alicia. Oh, and given that the things are so tall order, we don't want people to get freaked out or disencouraged. So really thinking of small wins that we can address. When you look at the strategies and the problems or issues that the community members brought forward, it could be overwhelming. when you look at all of the things that people need, and sometimes you don't know where to start. So we are really focused on finding small wins right now, so that our alliance feels proficient in moving the needle. And, sometimes it goes forward and then it goes back. It's not a linear process. So it requires a lot of mindfulness, collective mindfulness, to do this work. Edna or Keishla, do you guys want to add anything?
I think that one of my lessons learned is to be there whenever there's a need to discuss some topic, even though they're difficult to handle. Like, for example, it could be health access for our trans community. So it takes, you need to be there, show respect to the people on the topics they really need to talk, they really want you to talk and discuss, and making sure that you bring those voices to the table and invest in making more visible the needs of our community. So amplifying those voices can be very stressful and it weights you down sometimes. So the mindfulness is very important, as you mentioned, Marisaida, because you need to take that into consideration and maybe focus on those small wins, because the big ones are still in the process.
We just went through one last week. Dr. Khan was here with us. For the first time in the history of our alliance, the main dish was a behavioral scientist. So I was really excited. And we had a panel to discuss a very complicated issue, which has to do with mental health patients being incarcerated in Puerto Rico for lack of due process in our judicial system. So one of our partners is the Commission for Human Rights in Puerto Rico. So that was amazing that we were able to have that, and people responded very well to understanding and asking questions. We have over 200 citizens incarcerated right now because they haven't been evaluated psychiatrically, even though the judge already said that they shouldn't be in prison. They should be in a mental health facility in less restrictive environments. So we were very successful in the morning with that topic, but completely unsuccessful in the afternoon with our panel of trans citizens and trans health. Nobody showed up other than the community members. So we were talking about, is the alliance ready? What does it mean that only the community members showed up? Should we be disencouraged? How do we expose the topic without re-victimizing our colleagues from community with trans health issues is very complicated. So just to give you an example of, doing this work, it's never boring, but it could be very challenging.
If I could ask a question, just to go back to some of the successes in community engagement and looking through the lens of COVID, I know that Edna and Marie, you mentioned some of the assets that exist in Puerto Rico to reach such high vaccination rates. But at the same time, the amount of funding available to Puerto Rico per capita is still one of the lowest in the entire United States. And other places in the US also have that same geographic boundary situation that many small states do. The asset around having political alignment, I think, certainly is an important one. But again, we have that in the US as well in some cases. Certainly in Delaware, we have a uniformly political representation that actually favors having vaccination. So there are those assets elsewhere. There's something else happening there about community engagement and alignment that I think is a real skill set to be explored in the future. So I think I give full credit to community engagement for getting that work done. And I think in particular, because in the US, when we reach lower than expected vaccination rates, folks who don't know better, sometimes they will blame minority communities. And that is, incredibly unfair, of course. But I think you've demonstrated that a majority minority community has in fact achieved the highest vaccination rates in the entire country. So I think that's a really important case study. But from the same lens, I wonder if you'd comment about minority communities, non-English speaking, perhaps ethnic, non-Latino communities within a predominantly Latino community. And Maria, I know you and I have spoken about that a little bit, if that could be interesting to explore. Do you want to talk about that, whether that work is coming out in your community engagement surveys?
Yes, and what Dr. Khan is referring to is that we have within Puerto Rico, we're not a monolithic group. You know, we have a huge Dominican migrant population, although they're Spanish speaking, but we also have a Chinese, very long lasting since the 60s, Chinese community. We have a lot of Middle Eastern community in Puerto Rico. And so, no, not yet. We haven't, Edna, I don't know if in the other RADAX funding, other of the researchers you're working with, at least in our work, we haven't explored that. We explored the Dominican community piece with the migration and documentation issue, but do you know if anybody else is working on the Chinese community or the Middle Eastern community?
In the Middle Eastern, there's some work on dental health, but there's so limited, it's very small, a scope of researchers that are interested in this community. So it's one of our tasks to, visualize these communities more. In the process, we are helping identifying those community leaders because they are very, maybe in the social media, very active, but it's part of our plan. But we are very far from that.
Yes. Our other project is focusing more the funding we got for rapid response for COVID. And then and our colleague Carla Mari, who's part of the leadership, is here as well. We're focusing on elderly who are physically isolated, homeless, LGBTQ. That's our main focus right now. And we're partnering with aqueducts, people who work in communities who don't get the water from the state, but from local, ¿cómo se dice? Pozos.
Community water systems are.
Yes. I'm sorry, that's where my English gets bad. Wells,
exactly.
Thank you.
Thank you.
Thank you both.
Thank you,
Dr. Salvatore, would you have any other thoughts, or would you like to open up for any questions from the group before we close it out?
Yeah, I think I just saw one comment to me in the chat. I think it was from you, Laveda. So a question about how we're working with the Promotor program out of the Cancer Center. So they were partners on the Latinx community survey that I shared. And also, yes, we're absolutely working with them. They have some of the promotoras have participated in the qualitative research I shared. And also we are partnering with them with different other initiatives that we're doing with the Latinx communities and patients. Happy to answer offline as well, Laveda, if you want to talk more. Yeah.
The contact information for the session chairs is going to be as part of the main program as well. So I hope that you all can connect. So again, thank you so much to everybody for participating. I just want to mention the event that Marie just mentioned in Puerto Rico. The keynote speaker was a psychiatrist, a very well-known psychiatrist and psychiatry research colleague from Mass General Hospital in Boston. She is originally from Puerto Rico, Dr. Margarita Alegria, and she talked about research in Latino communities. And she highlighted a really important paradigm, which is when we have funding for conducting research projects in individual CTRs, such as Delaware and Puerto Rico, she had used the funding she had in Massachusetts to specifically look at the Latino community. Then she drilled down further into the Puerto Rican community, and then is now partnering with colleagues in Puerto Rico to explore that further. So research is iterative. It builds upon bits and pieces. As long as each layer is done well, you can keep building upon it, and that's how knowledge progresses. So I encourage all of us to think about how to collaborate across our silos. These CTRs are here so that the community and researchers can get together. I hope you connect, and we have pilot program funding through each of the CTRs, Puerto Rico and Delaware, to be able to support good ideas. So no matter where you want to do your research, partner with a good PI, become a community PI. As I saw when I visited San Juan last week, there was a community PI who works with those who don't have a home, the homeless folks. And he's so glad that he has an NIH ERAS number, and he's thrilled to be able to participate as a community investigator. So we would love to get you involved in that work. So again, I want to thank you. I want to especially thank our session co-chairs, Dr. Acosta, Dr. Salvatore, Dr. Sanchez, Ms. Hernandez, for your participation. We hope to see you very, very soon.
Gracias. Very nice to meet you.
Thank you. I think we have a few more minutes before we need to return to the main session. So if anyone wants to stay on or has questions or comments, we'd be happy to receive them.
Research.
We could have probably a very interesting session on just the use of promotoras in a variety of health settings across different areas, because we learned about that from Latin cultures for the most part, and we're now implementing that in our cancer center here at Christiana Care. We have for several years now. It's an excellent program that some of the folks, in fact, on this call may or may not be on here anymore, but were involved in. So we hope to maybe continue thinking about that in the future as well.
Yes.
And I'd add to that, community health workers is a major investment that we have. We have community health workers on our food pharmacy, embedded in our primary care practices. Many of our primary care practices, women's health, our school-based health centers. And certainly that is building upon the rich history of grassroots kind of promotora models that you're talking about, Dr. Khan.
Is that true also with maternal child health?
Yes.
Yes.
And
We have
for us
they
in
call
Puerto
home
Rico.
visitors or promotoras home visiting. Yep.
And Edna, Dr. Khan, this is something, if there is interest, Ms. White, Edna has been the PI of a beautiful program that uses that model with maternal child health. We have been doing it for how long now, Edna, your project?
It's our 4th year.
Yeah, and we have 2 in the island, one directed by Edna and another one directed by another of our colleagues. And what we did is we did a geographic corridor. So we went after funding on purpose to connect both programs so they overlap in one municipality and collaborate. And it took a lot of diplomatic missions to achieve that, but we were able to create this beautiful corridor in high-risk areas. So we have a long tradition of using the promotora model in Puerto Rico, not only for maternal child health, although that is our experience in our team, but in many other areas. So
I'd be interested in that as well. And also I think not having the politics involved with the COVID, because here I serve on the Wilmington COVID mobilization group, and the Black and Hispanic rates are still lagging far behind the rest of the population. So any information I could get to help move that along, move that needle over, would be really much appreciated.
how much, and I don't mean, until what time is this session? I don't want to open this kind of worms that I'm about to open.
3 o'clock.
Okay, so Ms. White, how much of that do you think has to do with mistrust of the establishment, given what has happened historically? Which, it's interesting because we have that issue here too with the sterilization of Puerto Rican women. It's not like women being used as guinea pigs, but I wonder, there's a qualitative difference there in terms of, I don't know, Dr. Khan, you make me think. My own biases.
There's a whole work being doing that now with the ACCEL program, which is a NIH funded effort. And what they have been doing is leveraging on the community proxy. So what you do is that person that you trust on the most, you try to engage those into promoting the same message. You have to choose what is the message we want to, make through the community, and just choose that message and that proxy trust. And for a couple of months, just dedicate to that. That's one of the strategies they have been using, and it's been very successful so far.
And it's not like there's not anti-vaxxers in Puerto Rico. There are, but qualitatively, the reasons they give you not to vaccinate are different.
Mistrust was primarily the main reason in the beginning, but now, and particularly among the 18 to 34 group, is everyone else is getting vaccinated, so why must I? I don't believe in it. I don't want any foreign substances going into my body. So a lot of that is, if everyone else is getting boosted, why would I need to? I'm protected.
That is the feeling of the anti-vaxxers in that age group in Puerto Rico. However, we have structural interventions promoted by our government. In other words, I don't know if you heard, we were the first jurisdiction to have lockdowns. Like, we had restrictive movement for a couple of months, and our executive orders have empowered employers, where now employers are empowered legally to require that their employees are vaccinated, triple vaccinated. So therefore, legally, you can't go to work. And in terms of school, they won't take your children in the school if they're not vaccinated. They have to be vaccinated. So there's structural level interventions mixed with good accessibility. Like, you could go to the drugstore, Walgreens, CVS, the state, municipalities.
Yeah, that could be a little bit challenging, because you can, isolate people with that kind of aspect, which is one strategy to follow. The other one is to provide options to the person that doesn't want to vaccinate. Okay, you don't want to vaccinate, it's okay, but what are you going to be doing to protect yourself and your others? So you need to use the mask every time. That's the minimum responsibility you could do. Okay, do not vaccinate, but you need to protect yourself and the others. How do you do that? Make sure you water you wash your hands and you use your mask every time. So that's like, that person has another option to do, but it still requires responsibility. So that's one
mask use compliance. And the other thing that is happening is, there's a distinction between our municipalities. Some are called autonomous municipalities. They have more access, but what they're doing, which is wonderful, is that they have this drive-through testing sites all of the time. They're free. And it doesn't matter if you live in a different municipality, you can go and use it. Not to be confused with the fact that we still have pockets of elderly who are in very, very remote places. And part of our other project is we're going to bring the testing to them, because they're isolated, their children have migrated. We have more elderly under the care of the state than children. There's 4,000 elderly under the care of the state and 3,000 kids. So we have an elderly emergency, and many of those elderly, they have no family. They're gone. So.
Wow.
So we have a couple of really interesting questions that I think we could probably tackle together. So Anna Saylor asked a question about recommendations for establishing community partnerships with Latinx communities, given the stigmas and previous experiences with research in healthcare institutions. And then Suzanne Milborn, who works with the VA system, is talking about engaging veterans in research as well. And I'll just add that from the perspective of engaging communities to work with a particular group, such as in this case, Latinx communities, nothing is more effective in my view than engaging scholars and communities who have common interests. So if you have scholars who have a track record of working in Latino health and who are perhaps themselves invested in that, such as colleagues from, in this case, the University of Puerto Rico, that I think inherently leads to a certain degree of trust, that we care about this issue enough to bring in the experts like yourselves today to our Delaware session here to hear about it, as opposed to speaking about an issue in isolation, right? Nothing about us without us is the whole idea. And we might still not have a complete picture, even by including more voices, but we will get to a more complete picture, right? We will get closer to that truth. So I think the first question is around how do we engage experts who are from the community themselves? They could be community researchers, or they could be community members themselves. The second question is very interesting about the VA, and I'll highlight a point about Puerto Rico and the homeless community. But let me pause there, and Dr. Salvatore, turn it to you if you'd like to address that question too.
Yeah, so thank you, Dr. Khan. I think in terms of establishing community partnerships, especially in situations where folks have been marginalized, excluded, disrespected, perhaps worst case scenario, discriminated against. I think it's really important to just acknowledge that up front, right? I think when people have been traumatized, organizations, folks have not felt, they've been excluded for a while. I think it's important that that we acknowledge that. So really having conversations about what both sides need, interest, really starting where the people are in terms of, I might have an idea, I want to work on a diabetes project, but the community-based organizations might have a different priority. And I think it's really important. I think being able to, like Dr. Khan talked about, bring in leaders that have similar cultures, language. I'm not a native Spanish speaker, but I certainly make an effort to, have gotten a lot of training to be able to speak the language of my colleagues. I think is really important. So those are just a few things that I think have been helpful to me in the past. Not trying to sweep things under the rug, because those are the essential things that are really front and center in shaping health and relationships.
Dr. Sanchez and Dr. Acosta, how would you suggest, I'm sorry, Mari, go ahead.
No, I was going to say, Edna, it's our champion on this. So I think she should talk about how she has galvanized us with our community board. Estás en mute.
Yeah. Sorry, but I lost track of the question. I was involved.
Like, how do we engage? I'm going to blow your horn then. I think somebody posts trust, and I think that's really important. And Edna has done such a wonderful job of meeting halfway in terms of one point of convergence with our community members. So for many years, she created these community academic partnerships, the CAPs, and out of that grew our current community board, but she has been at it for 8 years. And really that trusting relationship, like what happened on Friday, we just had a conversation today with our community members about the fact that nobody showed up and what does that mean. So they see we care and we're honest.
Oh,
and,
yes.
With the whole trans thing we were telling you about. So I think trust, I think finding points of convergence where we can have small wins, but also talking about the long-term relationship, going for funding together with all the struggle that means, being transparent about the angels and demons of running a grant that we have now from a community platform, which is a structure of power. It is, and we're honest about it, and being an honest broker.
Being a partner, being there, whatever you do for your family, you have to do for your partners in the community. You need to listen, you need to be there, you need to show interest, and then they will get to know you and your expertise. But if you don't show sensibility, interest in partnership for something, an agenda in common, there's,
and acknowledging that everything is not going to be kumbaya. I think we're good at that in terms of we are going to have disagreements. How do we address conflict? And we talk about that before it arises, to say, okay, when we disagree, when we have conflict, how are we going to go about making decisions together?
Mm-hmm.
That's been our experience.
Yeah.
Thank you so much. I think the other question was around the VA and specifically engaging veterans who suffer from homelessness and Latinx veterans who suffer from homelessness. And Edna and Maria, I was reminded by the fact that at last year's Scientific Day in San Juan for your line CTR, the community engaged panel included the person who advocates for the homeless in Puerto Rico, or as he says, those without a home. He prefers that term to homeless. Mm-hmm. And this year, that person had now become a community investigator, as I alluded to earlier, and has an NIH and is actually an investigator on a grant. I wonder if we could potentially make a connection with your team who is advocating for those who suffer from homelessness in Puerto Rico and the Puerto Rico VA. And I'm sure Suzanne Milbourne can put us in touch with those colleagues. But Maria or Edna, would you comment on whether you're specifically working with homeless veterans in Puerto Rico in any fashion?
Our core, it's not, but the Alliance, we have representation. I don't know if in this iteration of our big board, we always had representation from the VA and from the portfolio of subsidized projects or supported projects. Edna, do you know how many we have from the VA?
I don't know how many, but we have had always. We have a good group of researchers that are invested with the VA participants and community. I mean, yes.
Yeah. So the Alliance has a good track record of collaboration with the VA hospital, both in integrating them in our leadership, but also, and that's historical, because before we were the Alliance, one of our founders had a double appointment with the VA. However, in terms of Francisco's, our community leader who leads homelessness efforts, his experience in terms of working for veterans that are homeless, I wouldn't dare to speak for him. I don't know, but that's something that we could talk to him about.
Yeah. But well, yes, I would love to keep in touch and making sure that we, provide opportunities for people that are experiencing homelessness at this moment, and the communities.
Very good. Well, thank you very much. And Alicia, do you think we should close out and head back to the main room?
Yeah, I think give people a chance to make a shift.
Great. Well, I want to again thank you everyone for participating in this session, and muchas gracias, mis colegas y amigas, and I wish you all a buena tarde. Hasta luego.
Bye.
Gracias.
Bye,
Thank you very much.
Alicia.
Bye, guys. Thank you.
Take care.